So good evening from India, from Mumbai, and good morning to my dear John. Good afternoon to Sameh, and I hope and I wish that all of you are happy enjoying this wonderful skull-based feast that Sameh has organized such wonderfully. He's such a great educator. John, you agree? Such a great educator.
And he's an ace. He's an ace.
Yeah. So I'm going to take you now to the world of trigeminal neurinomas. Trigeminal neurinomas. So trigeminal neurinomas are relatively rare problem. In neurinomas, they are second only to acoustic neurinomas. Acoustic neurinomas, of course, the most common. And rarely they are associated with neurofibromatosis. So we all know this. So in the year 2003, I published this series with 73 cases. I had analyzed 260 cases, personal cases operated by me from 1988 to 2017, 260 cases. And now in the next further 4 years, at least I have reached more than 300 cases of trigeminal neurinomas, which is without any question the largest personal series in the world. So with that power, I am going to talk to you. So this was my article in 2003, it is quite a well-cited article. And in this article, we introduced several beautiful things about trigeminal neurinoma. First beautiful thing is that we mentioned for the first time in the literature that trigeminal neurinomas arise from the region of Meckel's cave. It does not arise in the root, does not arise in the further roots of the trigeminal nerve. It arises in the region of Meckel's cave. That is one thing in this article. Second thing in this article, which was for the first time we mentioned, these tumors can be removed by an interdural, within the dura. These tumors remain within the dural confines of lateral wall of cavernous sinus, and this dura protects you during surgery. So this information was first time in the literature exploited for trigeminal neurinoma. The other beautiful thing that we mentioned in this article is that surgery, you can aim to preserve the function of trigeminal nerve. That is one thing. Not only preserve, but the aim of surgery is to improve the function of the fifth nerve. So that improvement of the fifth nerve function as a series was first time discussed in this article. So in this article, we mentioned that this middle fossa component of the tumor is interdural. In this article, we had mentioned that the posterior fossa tumor is intradural like acoustic tumor. But further articles of mine discuss that even this part of the tumor can be interdural. So the whole thing can be interdural tumor. And the fifth nerve are displaced by the tumor. So this information was not available 25, 30 years ago, and these tumors were quite complex and not many people operated on these tumors. So as you can see, we observe that most of the tumors arise at the entry of fifth cranial nerve into Meckel's dural cave. So this was one information. Second thing that we mentioned, this is my other article, trigeminal neurinoma with extracranial extension. And here we mentioned that we speculated the origin of even extracranial trigeminal neurinoma in the region of Meckel's cave. So even the tumor is extracranial, the origin of the tumor is in the Meckel's cave. And most trigeminal neurinomas, irrespective of the site of spread, have an association with the region of Meckel's cave. So that is these are the things that we discussed for the first time in the literature. The other beautiful thing that I already talked to you about is that you can improve the sensations of the fifth nerve. So this information, this kind of improvement of function was never discussed in the literature as a series. So trigeminal nerve is quite a big nerve. As you can see, this trigeminal nerve has been split. The carotid artery is very closely proximated to the tumor. And these are the third nerves which form, these are the three divisions of the trigeminal nerve. V1 and V2 form the lateral border of the cavernous sinus. Lateral wall of the cavernous sinus. So it is the trigeminal nerve is located in the lateral wall of the cavernous sinus. See this V1 and V2 divisions. V3 is exits before the cavernous sinus. So this is third nerve, fourth nerve, sixth nerve. So trigeminal nerve, these two nerves are located in the lateral wall of the cavernous sinus, and they have a very well-defined dura. So this is the basis. So this dura is a strong structure. Dura is a firm structure, and dura cannot be penetrated. That is the beauty. The dura, all the nerves and blood vessels which exit from the brain have a dural cover. So this concept that dura is strong and dura will be there. Dura is respected by the blood vessels and the nerves, and even the tumor respects the dura. So this is my concept, which I have discussed on several occasions. As you see, these papers are 25, 30 years old papers of mine, where we have discussed about how the arteries are displaced by the tumor. This is a very, during those times, this concept was not there in 30 years ago. So on the basis of arterial involvement and displacement, we identified the nature of the tumor, we identified the surgical strategy for the tumor, and we identified preoperatively what is the histological nature of the tumor. So some of these articles on cavernous sinus, I think they had big impact on trigeminal neurinoma surgery. So this is the paper. You see, this kind of arterial encasement will never be seen in trigeminal neurinoma, never. This kind of intracellular, this is pituitary tumor, or this is displacing the carotid artery. This kind of displacement of carotid artery is never seen in trigeminal neurinoma. This kind of trigeminal nerve, this kind of carotid artery encasement is never seen in trigeminal neurinoma. So these are the basis of identifying the trigeminal neurinoma. So trigeminal neurinoma, this is a very classical case of trigeminal neurinoma located in the lateral dural walls of the cavernous sinus. Carotid artery is displaced medially by the tumor. You can work within the tumor and you don't have to identify or define the carotid artery. This dura will protect. So this understanding is a very critical understanding in trigeminal neurinoma. The whole tumor is covered by dura, and you have to work interdural within the dural confines. And like for acoustic tumor, you are stressing for facial nerve preservation all the time. In trigeminal neurinoma, you must stress on preservation of trigeminal nerve fibers. And that is the aim. If you damage the trigeminal nerve fibers, then it is a failed operation and a huge complication. Because if V1 is lost, then corneal reflex is gone and the cornea will be damaged eventually. Tumors located entirely in the posterior cranial fossa are relatively rare. Even the tumors which are located in the posterior fossa, trigeminal neurinomas, have an extension towards the Meckel's cave, most of these tumors, or almost all of these tumors. The most common form of trigeminal neurinomas are these kind of dumbbells. As I mentioned earlier in my experience, we thought that this part of the tumor is intradural, but now I am quite convinced that a large number of these tumors, even there is a dural protection. So you can come in this direction, work within the dural confines, and you can remove this tumor radically, quickly, and effectively. The most important thing to learn about this tumor is how to attack this tumor, how to demolish the tumor, how to break this tumor. There is no need to coagulate these tumors. They are not vascular tumors. They are soft tumors. Sometimes they are like, maybe like nubbins, maybe they're here and there, but essentially they are confined and defined tumors. So these kind of dumbbells are very common in trigeminal neurinomas. More importantly, they come with a very classical type of presentation with numbness over the face, with wasting of muscles of the trigeminal nerves. Motor and sensory involvement are classical. On the basis of the clinical finding, you can say that this is a trigeminal neurinoma, because surgery on meningioma of cavernous sinus is different. Surgery for trigeminal neurinoma is different. The aims and objectives are different. The surgical style is different. So there can be a large middle fossa and larger posterior cranial fossa component. But you see, there is a defined, this is a very defined posterior cranial fossa component, and you can, these are one of the more important skull-based tumors and radical resection. I must tell you that 25, 30 years ago, surgery on trigeminal neurinoma was not frequently done, and people did not understand how to remove trigeminal neurinomas. So this is another large trigeminal neurinoma. So I'm going to show you several images so that you get a feel of these kind of tumors. Less frequently, but not uncommonly, these tumors extend along the divisions of the trigeminal nerve. So this tumor, we had reported extension along the lacrimal nerve. You see, along the V1 division of the trigeminal nerve. But there is a base in the middle fossa. The concept is that these tumors arise in the Meckel cave and then it goes ahead. So they can go along the V1 division of the trigeminal nerve, and essentially the surgery you have to define how to operate on these tumors. This is the tumor along the V2 division. You see, these are teeth, and this is along the foramen rotundum, and this is the V2 division of the trigeminal nerve, and they can go along the V2 division. More importantly, you must understand that the sixth nerve is medial, carotid artery is medial. You cannot come from this direction. This direction, if you come, you can hit the carotid artery. This direction you come, you can hit the sixth nerve. Lateral, working within the dura, is the way to operate on these tumors. So these tumors, this is along the foramen rotundum, very huge tumor, as you can see, and this has destroyed the teeth of this gentleman. And these can be this kind of extracranial extension of trigeminal neurinomas, not frequent, but not uncommon. This is along the V3, you see, along the foramen ovale. It is dilated here. There is extension in the middle fossa, and then there is an extension in the infratemporal fossa. So this is a trigeminal neurinoma. You will diagnose this tumor on the basis of symptoms. Numbness is one very big symptom, and wasting of the muscle is another big symptom. So these two symptoms, you can diagnose that this tumor is not some malignancy, or this is the most benign tumor of the body, and you can remove it radically and you can remove it effectively. This is another tumor which you can see there is a bulge over the lateral part of the face. This is in the posterior cranial fossa, this tumor. Then it is in the middle fossa, then the infratemporal fossa, then along the division of the trigeminal nerve. So along in all the four compartments, this is of course a rare situation, but this was one of these kinds of tumor. So in my series, many of these tumors, you see type A is only in the middle fossa, type B is only in the posterior fossa, type C is dumbbell shaped, type D is when there is an extracranial extension. So trigeminal neurinomas can be very small, as you can see here, or they can be huge. You see, huge trigeminal neurinoma. As I mentioned, even small trigeminal neurinomas, the symptoms are classical, and even in the large, they are classical, numbness. Many of these tumors are soft and necrotic. You see cystic changes, necrotic changes, going extracranially, going in the infratemporal fossa, along the foramen rotundum, in the infratemporal fossa. These tumors, this division of the trigeminal nerve, this is a very This is a benign tumor, large tumor, but benign. And this is a trigeminal neurinoma. This is another huge dumbbell-shaped trigeminal neurinoma you can see. And necrosis is the key feature. This is common in trigeminal neurinoma. Necrotic change, not, you see, they are like neurofibromas and schwannomas, firm, nodular, but necrosis and soft cystic changes are frequently identified in trigeminal neurinomas, like you see in this case. So many of the tumors in my series have been very huge and large. The other very beautiful feature of trigeminal neurinoma, you see there is a cystic change. This is a whitish cyst, and this is like a craniopharyngioma. No other tumor. This is a contrast enhancing firm part, and this is the cystic part. Samay, you can hear me properly? Samay? John?
Yes, we can hear you.
Okay. So there are two components. There is a largest cyst here, and this is in the middle fossa. Another beautiful feature that I'm showing you is this is the cyst, and there is a fluid level. There is a fluid in the cyst, and there is a fluid level in the cyst. So this is uncommon, but it is seen in trigeminal neurinoma, this kind of fluid level. Now you see carefully this tumor going in the middle fossa, and there are multiple fluid levels in this tumor. You see there is a fluid level here, there is a fluid level here, and there is a wall of the tumor. So this is a trigeminal neurinoma with fluid levels. You carefully see this tumor, and you see there are many fluid levels in this tumor. You see here, here, here. So multiple fluid levels in this tumor. And I have to tell you that tumors with fluid levels like this, it may be due to bleeding within the tumor or due to the consistency of the tumor, the proteinaceous content of the tumor. And whenever you have a fluid level, these tumors are more aggressive in nature, and the recurrence rate is much higher in these kind of tumors. Bilateral tumors, neurofibromatosis is always associated with bilateral trigeminal neurinomas. You see, but which tumor to operate and which tumor not to operate. In neurofibromatosis, you don't have to operate all the tumors, but bilateral is a frequent observation in NF2s. You see another NF2 case, there is an acoustic tumor, huge acoustic tumor, and on this side, and there is a trigeminal neurinoma on the other side, and you see they are almost touching each other. So this is a very beautiful case for your visual delight, and you enjoy seeing this slide. They are almost kissing each other, acoustic and trigeminal. I don't think such a beautiful case has ever been shown in the literature. This is another case of NF2 where there is a trigeminal, there is an acoustic neurinoma, there is a facial nerve neurinoma, there is a sixth nerve neurinoma, there is a fourth nerve neurinoma, and there is a trigeminal neurinoma. So there are multiple neurinomas in this patient, and you can see this kind of in NF2. Now you have to decide which tumor to remove, which not to remove. Of course, this is a very important decision. This is a bilateral NF2 trigeminal neurinoma, and you see there is ossification in the tumor. There is bone formation within the confines of the tumor, and in my series of 300 cases or more, I have identified ossification in trigeminal neurinoma in 4 cases. So ossified trigeminal, this is an extremely rare kind of situation. Now, this is a trigeminal neurinoma, and this is a retroorbital tumor. This is retroorbital tumor is a hemangiopericytoma, and this is a trigeminal neurinoma. So this trigeminal neurinoma associated with another tumor related to the eye. We had thought that both the tumors are same, but this was different and this was different. And we operated, you see, this is a highly vascular tumor, and we removed first this orbital tumor and then this trigeminal neurinoma and this tumor. Both these tumors were removed. And I have a follow-up of this young boy for more than 24 or 25 years, and he's completely asymptomatic. Of course, he does not have vision in the affected eye. Many of these trigeminal neurinomas are in middle age group people. You see many of these in my are in middle age group. Very rarely we reported in infant, you see 18-year-old child with tumor and presenting with proptosis. This was I reported several years ago, 25 or 26 years ago. So the more important thing is how to diagnose these tumors. They have characteristic clinical features. Symptoms of trigeminal nerve involvement like numbness in the distribution is very important and characteristic, and wasting of the temporalis muscle and masseter muscle is very characteristic. Wasting. So if you have these two features, it is a trigeminal neurinoma, and accordingly you have to operate. So motor and V1 is quite commonly involved, V2, V3 and motor is quite commonly involved, and there are various kinds of symptoms. Most important is almost 100% numbness, almost 100% wasting, and you will see one very important symptom that we reported, pathological laughter. You see, in this kind of large dumbbell-shaped tumor, we reported 4 cases where the patient presented with the primary symptom of pathological laughter. They have characteristic radiological features like petrous apex is eroded, carotid arteries always displaced medially. They are confined to the dural spaces as I have mentioned to you. In my own series, we had made errors in diagnosis, like we thought this was a trigeminal neurinoma, but this was a tuberculoma. We thought that this was a trigeminal neurinoma, but this was an aspergilloma. We thought that this was a vascular trigeminal neurinoma, but this was a hemangiopericytoma. So trigeminal neurinomas will never be vascular like this. So if you have a vascular thing like this, it is either a meningioma or some other kind of tumor. In 1991, 30 years ago, I had thought that this was a trigeminal neurinoma, and we had attacked this like a trigeminal, but this was a heavily vascular tumor, and this was a cavernous hemangioma of the cavernous sinus. You see the carotid arteries encased by the tumor. Such encasement will never be there in trigeminal neurinomas. So trigeminal nerve is a beautiful nerve located in the middle fossa floor and surrounded by a very firm and sturdy dura. And that makes it relevant. This dural relationship makes the surgery, and you have to design your surgery according to what you understand about the dura. So surgery on trigeminal neurinomas in 1992, so 30 years ago, my own understanding and understanding of the world at that time was these tumors should be removed in 2 stages. It was Mallis who said for the first time that these tumors can be removed in 1 stage by a middle fossa approach. But in 1992, my personal feeling was that these should be removed in 2 stages. First, the larger tumor should be removed, and then the smaller tumor should be removed. So here you see, first I had removed the cavernous portion of the tumor, and then I removed the middle fossa tumor. So this was a 2-stage surgery in 1992, 30 years ago. In 1992, similar trigeminal neurinoma, I first operated by posterior fossa route, and I removed the posterior fossa component of the tumor, and then I removed the middle fossa component of the tumor. So this is a 2-stage surgery, which I was also doing personally, and the whole world was doing at that time. So then we designed our own strategy that surgery for the middle fossa component, you have to play with the dura, and surgery for the posterior fossa component, you have to play with the dura and sometimes with the arachnoid. So this is trigeminal nerve. There is CSF around the Meckel's cave. This is the tumor. This is interdural, and many of the time this portion is also interdural. And this was extradural approach to cavernous sinus tumors that we described for the first time in the literature in 1997. Tumors for cavernous hemangiomas and for trigeminal neurinomas. Of course, then Vinko Dolan had described vascular lesions in Moscow, also for trigeminal neurinomas, but for intracavernous sinus, so we understood how the dural relationship of these tumors are. And this was my book, which was published in 1996, where we have discussed all these kind of things. So one sentence which I like to talk for last 35 years, that alum al dimag from Arabic legacy, that meninges are the mother of the brain. This sentence is my very popular and very, I like this sentence because the tumors respect the dura. Now in 1995, I described this approach, infratemporal fossa interdural approach. You see, in 1995, what we did was we did not do any craniotomy. We just removed the zygomatic arch. You see the hands of the surgeon just widen the foramen ovale and remove this tumor. So this approach we described, infratemporal interdural approach, in 1995 for the first time in the literature. A tumor, which cavernous sinus tumor, which were considered to be very difficult tumors at that time, and even now, was removed without craniotomy. So this was a beautiful evolution of surgery of these tumors. So in my paper in 1995, I had shown some pictures. So this was the tumor, small tumor, which was removed by widening of the foramen ovale without craniotomy. Now you see, beautiful, in 95 article, I had shown the tumor which is going in the posterior fossa. I had done without craniotomy. Just open the dura, work interdural, and follow within the Meckel's cave into the posterior fossa. And this is my craniotomy. Just widening of the foramen ovale without doing any temporal craniotomy. So I think in the growth or development of trigeminal neurinoma surgery, this was one very important article. This was also in the same paper of mine in 1995, which the tumor we had removed without any craniotomy by infratemporal interdural approach. Of course, now I don't do that approach because now I like to come subtemporal, open the dura, work within the dura, demolish the tumor, work, respect the dura, don't coagulate unnecessarily, and most of these tumors can be removed in 20-25 minutes or half an hour, not more than. If I remove a trigeminal neurinoma in more than 1 hour, it will be a very difficult trigeminal neurinoma. I don't do that. So this is acoustic tumor. It arises from the internal auditory meatus. Like trigeminal neurinoma arises from the Meckel's cave. And then this tumor grows. So I am still studying the dural anatomy of this tumor. I will like to discuss this dural anatomy later. Now this is another C2 ganglion. This is C1 arch atlas, C2. This is C2 ganglion. This is similar to trigeminal nerve. This is the largest ganglion of the spine. Gasserian ganglion is the largest ganglion of the brain. Here the tumor, when the tumor C2 neurinoma arises, it arises outside the dura and behind the bones, behind the joint. And there is a well-defined dural cover of these tumors. So I had published this series. Let me, I'll show you that. Like trigeminal neurinoma arises from the Gasserian ganglion. It is in relationship to cavernous sinus. It is in relationship to the carotid artery. C2 neurinoma arises here. It is in relation to vertebral artery. It is related to the venous plexus here. Now you see this drawing in this is trigeminal neurinoma. This is C2 neurinoma. This part we had discussed that this is interdural, and this part we had mentioned intradural in my article. So this part is, now we are quite convinced that this part is also interdural. The whole tumor is interdural. You don't have to do laminectomy. You open the dura here. You don't have to expose and control the vertebral artery. You work within the dura and work within the dura, and the whole tumor can be removed in very quick time. So this whole tumor is interdural, working within the dura, working within the dura. You can remove this tumor in 10 minutes or 15 minutes, like trigeminal neurinomas. So bilateral C2 neurinomas, like bilateral trigeminal neurinomas. So this is how I have developed. In 2008, I had studied 60 cases of C2 neurinomas, where I had said that this part of the tumor is intradural. And in 2018, I studied another 50 cases of C2 neurinoma where I said that this part is also interdural within the dura. So the whole tumor is interdural. You work within the dura and you remove this tumor. So this was my understanding. So this is C2 neurinoma, very similar to trigeminal neurinoma. Another tumor which I discussed is oculomotor nerve neurinoma. You see, this is a large oculomotor nerve neurinoma presenting with oculomotor signs. And we discussed for the first time in the literature that this entire tumor is interdural in location. You work within the tumor, don't try to remove dura, and you can save the third nerve. You see, interdural oculomotor neurinoma. So our philosophy is that these tumors arise in the oculomotor system and the dura covers these tumors. So this is interdural tumor. You work within the dura, and you can save the third nerve function, which has never been reported in the literature. So third nerve neurinoma arises in the oculomotor system. And you see there is a beautiful dural cover that you have to protect during the surgery. Demolish the tumor, learn the art of breaking the tumor without coagulation, and you can save the third nerve fibers. Sixth nerve neurinoma is within the cavernous sinus, and when carotid artery is encased, it is sixth nerve neurinoma. Now you see beautiful, I am showing you seven nerves. Seven nerve arises in the region of geniculate ganglion, and the whole tumor is interdural in location. You come from lateral, you demolish the tumor within the dura. Do not try to remove this dura. Try to work safely around the facial nerve, and you can probably save or improve the facial nerve function. I'm not saying I have improved the facial nerve function, but the thing is you can make the surgery very simple. These are soft and necrotic tumors, and you can do a very rapid fire job. This is seven nerve neurinoma. Work within the dura and don't try to remove this dura, and that forms the basis of my surgery. This is another seven nerve neurinoma that we have removed. This is immediate post-operative period scan. Same strategy. You see, interdural for lower cranial nerve schwannoma. Lower cranial nerve schwannomas arise in the region of the petrous bone, and then the whole thing, even the posterior fossa component of the tumor, this whole thing is covered by the dura. So take a transverse incision, work within the dura, and that is the way you can improve the function of the lower cranial nerves. And there is no question in my mind that you can do a radical job by preserving the dura. And if you demolish the dura, you will take the lower cranial nerve. So these things are discussed in my articles on the subject. Now coming back on trigeminal neurinoma, in 1996, I published this article where we said that you can do a basal temporal craniotomy, removal of the root of zygoma, roof of condyle, roof of external ear canal, partial mastoidectomy. This is the approach I discussed in 1996. I do not use this, but this was at that time. Dr. Samay, you stop me whenever you want to stop me, okay?
Just 5 minutes, see you.
5 minutes.
5
okay,
minutes.
so let me go rapidly now. So this is the approach I had described, basal extension for middle fossa approach. This was the incision, which was quite a new incision. Temporalis muscle was rotated anteriorly, and then this bone work was done, mastoidectomy was included, and this was a beautiful exposure, and then work interdural, and this was the exposure. So basal so this is the craniotomy, this is the root. This was a very big craniotomy at that time. I don't do such big thing now. So this is the root, and this is the condyle and mastoidectomy. I don't do all these things now. So this currently I use just this exposure, splitting of the temporalis muscle, do a smallish craniotomy here. In tumors which are located anteriorly in the middle fossa, I take the craniotomy little anterior. So this is my work. So this is the tumor, and you see, I don't want to show the videos because this, you have to learn the art of demolishing this tumor, work within the dura, and you can remove these tumors beautifully and effectively. You see, Now I will show you several preoperative. You see, they are eroded. There's never a need to drill the petrous bone. There's never a need to drill the anterior clinoid process. Just come from here or middle fossa, take lateral position, cut the dura like this transversely, and then work within the tumor, and you can do a beautiful resection. This is preoperative, postoperatively. Tumors which are located middle fossa, I come little bit anteriorly and then retract the dura and then work within the dura. So this is another tumor, preoperative, postoperative. I don't want to show you the video, unfortunately. This is the tumor. And you see this tumor has already eroded the anterior clinoid process and the petrous bone. There's no need to drill these things. This is preoperative and postoperative. You see the beautiful tumor resection. This is a smallish tumor, which is of course a relatively simple tumor. This is a huge tumor where you can work within the dura, and remove this tumor very beautifully. So tumors which are going in the posterior fossa, you can make a tentorial dural flap and work either through the Meckel's cave or make an incision and then work within the dura. So this is the tumor. You see, this is a gem of a tumor for a skull-based surgeon. And I have already told you that learn the art of breaking the tumor, learn the art of demolishing the tumor without extensive coagulation. You should save the fifth nerve fibers. If you don't save the fifth nerve fibers, it is a complication of surgery. You see, this is a huge tumor. This is another big tumor. You see how the petrous bone and anterior clinoid are eroded by the tumor. This is another tumor. You just enjoy these tumors and see the world of trigeminal neurinomas. And this is a multi-cystic tumors. As I mentioned to you, there is a possibility of recurrence of these tumors. Even when there is a nubbin, this nubbin is not intracavernous. This is between the dura. You work within the dura and make a beautiful total resection of these tumors. You see, eroded. There is no need to drill the petrous bone. Work within the dura, respect the membranes, and you can do a terrific and beautiful job even for these massive tumors. And when there is necrosis, when there is cyst, there is a possibility of this immediate post-operative total resection of these tumors. You see, what is more important is preservation of the trigeminal nerve. Believe me, you have to preserve the trigeminal nerve. And if you know how to break this tumor, you can rather easily preserve the trigeminal function. I am saying not preserve. You should improve like acoustic tumor. You should all the time worry about the trigeminal nerve. And you see many of these tumors look very similar. Erosion of the petrous apex. And these are the tumors which have been beautifully resected, as you can see. So this is another tumor. This is a smallish tumor. This is a biggish tumor. This is a little bit okay kind of tumor. This is a large tumor. And you see, you have to see how these tumors, another big, huge tumor, work within the dura, respect the dura. No matter how big this tumor becomes, it is dura respecting tumor, and you have to remove this tumor accordingly. So this is another huge trigeminal neurinoma which has been removed, which has been demolished by a beautiful surgery. This is another tumor. Now, more recently for these large tumors, I come even supracerebellar approach I'm doing. I will show you some of these cases. Cystic tumors, you have to remove, you see, completely respect the dura and remove this radically, because recurrence rate, this tumor, the recurrence, this is recurrent same tumor, and then you have to work. Even the recurrence is within the dura. That is a beautiful, I will show you that article. And this is a recurrence of another cystic tumor. And then this is, I reoperated and removed this tumor. So cystic necrotic tumor. Some trigeminal neurinomas go in the posterior fossa, and nowadays I do them supracerebellar and retrosigmoid approach, and then follow this tumor in the posterior, in the Meckel's cave. So this is that kind of approach. This is another tumor by supracerebellar approach. Resect the tumor, go along the Meckel's cave and remove this tumor. So you see, this is another tumor strategy which I am using nowadays for tumors which are going very much posterior or very much downwards. This is in the cavernous sinus. This is another similar approach I used. You see how this tumor I have removed from the supracerebellar approach. This is another tumor by supracerebellar approach. This is another tumor by supracerebellar trigeminal approach. This is another one by the same, which I am recently liking it very much. This is also supracerebellar and removal of even the cavernous sinus portion of the tumor. So extracranial tumors which extend, you can do by, reverse skull base. Even the extracranial part is within the dura. That is beautiful understanding. This dura is present even in the extracranial part of the tumor. I wanted to show you, just see, Samay will allow me a few more minutes because he's my good friend. And Samay likes to see these cases. You see how the dura is covering the middle fossa, and also the extracranial part of the tumor, the dura is covering. This is a very old slide of mine. I don't like to show such blood and all those things, but I wanted to show you the dura. You see, this is the middle meningeal artery. Let me show you the dura. You see how this is I have drilled this part, and the dura is covering even the extracranial part of the tumor. And then you have to take an incision. You see this, how the dura is covering the extracranial part of the tumor? Then you take the incision and work within the dura. So this was my paper. And here also you see it displaces the artery, and the tumor which is going in the orbit, you can work within the dura. And that is very important. Reverse transcranial approach. Transcranial for this, not from the nose and not from the ears and not from the mouth, but transcranial. Make a smallish exposure. You see this post-operative work within, have a beautiful control, respect the dura, and you can remove these tumors beautifully. You see this tumor, and there is a complete resection. This tumor, how it is covering the dura, and you see this, how it is going in the infratemporal fossa, 3-compartmental tumor, beautiful. Just a minute, my friend. You see, this is another tumor. You see, this is my smallish craniotomy here, and then I work extracranial and remove this tumor. This is another tumor going in the extracranial infratemporal fossa, removed by a smallish reverse. Now, this tumor I showed you here in the 4 compartments, and I removed this tumor. Here is the video, but Samay is saying no time. This is another tumor. And you see these tumors have been removed very effectively and beautifully by a reverse transcranial approach. Now I want to show you apoplectic. When the tumor recurs, even the recurrence is in the dura. You see, this is a recurrent tumor, it within the dura, and you see how I have resected this tumor within the dura. This is a tumor, and I have resected within the dura. This is a recurrence also in the form of apoplexy. So I don't want to continue further. Chordomas are different, and trigeminal neurinomas are different. So thank you, my dear Samay. I hope I took you to another world of trigeminal neurinomas. I hope you have enjoyed this world of trigeminal neurinomas. This is a beautiful tumor for a skull-based surgeon. And, I just love these tumors. So thank you, Samay, for giving me this opportunity. And my best wishes to you. You are indeed contributing a lot, like John is doing. John Bennett has taken neurosurgery in all the corners of the world, and you are his good friend and my good friend. Thank you very much.